So if you have artery plaque, clogged arteries, and you're worried about heart attack and stroke, but you really can't take aspirin because it irritates your stomach or it causes bleeding or you're allergic to it, you're not alone. Not at all. Let me read you a few comments from our recent video on aspirin. Here's the first one. I have plaque, but aspirin wrecks my stomach. Now what? Here's another one. I was told to stop aspirin. No plan. No, let's reevaluate. No, let's understand the risk better. No, let's look at other options. Just stop. What do I do? Here's another one. I'm scared of bleeding, but I'm more scared of having a heart attack. And I'm even more scared of having a stroke. So these remind you of you. You're not confused. You're not alone. You're stuck. You're stuck between two very real risks. On the one side, heart attack or stroke, and on the other side, bleeding. And the worst advice in preventive medicine in this space is just stop your aspirin. I'm not here to scare you or to force a drug. I'm here to keep you out of the emergency department. So today I want to show you how I actually think about this problem. I'm presenting this like a decision tree. Very, very practical advice, 3 questions, clear forks in the road, and by the end, you'll know what to do next. So stay with me, we'll go there. In order to understand what we need to do next, you need to understand a little bit more about what aspirin is, what it does, and in order to understand that, you need to understand what a heart attack or stroke is. And this won't take long, but it's stuff you need to know. Heart attacks and strokes are not 90% blockage of an artery. Instead, there's soft plaque, inflamed plaque, unstable plaque. Here's the problem with unstable soft plaque. It ruptures, platelets rush in, a clot forms, blood flow drops because the clot gets too big and pieces of that clot float downstream. And if those pieces are big enough and they go to the heart, that's a heart attack. If those pieces of clot, if that clot is big enough and it goes to the brain, that's a stroke. And then that blood flow stops to that area of heart tissue, and heart tissue starts dying. And again, often worse yet, if it stops blood supply to the brain starts dying. That's where aspirin works. It makes platelets less sticky, but platelets can also help you heal. So the same drug that prevents clots can also cause bleeding. So that tension between slowing down clots and increasing bleeding versus decreasing vascular events, that tension is the entire story here. So I said we were going to go to 3 forks in the road. Let's start with the first fork. This really decides almost everything for most people. Do you have plaque? If you don't need aspirin. Plaque in your arteries. Not plaque in your teeth, plaque in your arteries. Aspirin's not about age. It's not about LDL alone. You know, we covered this thing about age hard in the earlier video where it used to be a thing where they said, after a certain age, you should take aspirin. Well, the U.S. Preventive Services Task Force has changed that, and for good reason. If you're 60 years old or 65 or 70 or 80 and you don't have any plaque in your arteries, you don't need aspirin. It's about plaque. Evidence of plaque includes CIMT showing plaque, a calcium score above 0, coronary CT angiogram showing plaque, prior heart attack, stent, bypass, these kinds of events, peripheral artery disease, which we covered in a recent video, carotid artery disease. Now, again, these are all significant forms of vascular disease and risk. Here's an important clarification, and this matters. If you've already had a heart attack, a stroke, a stent, or a bypass, these events, that's classic secondary prevention. Everybody agrees on that. Here's where the disagreement occurs. If you haven't had any of those events, the heart attack, the stroke, the stent, the bypass, but you have plaque, you're still often labeled by people that don't go too deep into this as, quote, primary prevention, meaning you don't have any problems. Well, let me clarify something. Cardiovascular disease, CV disease, really isn't cardio disease so much as it's vascular disease. And if you have plaque in your arteries, you've got vascular disease. The risk is real. And that vascular disease can result in the events that we're talking about. Clots go into your heart or your brain or some other places too, but those are the two big ones. We treat it more seriously when you have plaque, because you've already demonstrated that you do have artery disease at this point, vascular disease. And remember this, so a calcium score of 1 is not really the same as a calcium score of 500. In most cases, the risk is greater. Now, once you get up to 1,000 or more, that may be a different situation, which we're not going to talk about. We've talked about that in other videos. So severity does change decisions. Now, plaque is not dangerous because it blocks the blood flow. That would be like indoor plumbing in a bathroom or a kitchen. So aspirin does not fix plaque. What it does is one thing, but it does it very well. It reduces the chance of a clot forming on an unstable plaque. Now, that's why you had to go through all of that mechanism business in order to know what to do next. Thank you for your patience. Now, let's go to the second question. What is your bleeding risk? Higher bleeding risk includes some things that we know about. A prior stomach or colon bleed, GI bleed, gastrointestinal, a prior brain bleed, active ulcers, severe gastritis, chronic anemia, anticoagulants on board like Eliquis or Plavix or heparin, frequent bruising, frailty, heavy alcohol abuse. Heavy alcohol use is a big issue for bleeding. NSAIDs. Now that stands for non-steroidal anti-inflammatory drugs, and the most common ones are Motrin or Naproxen. If you're taking those layered on top, that's a big added risk for bleeding. And for aspirin, there is such a thing as aspirin allergy. You get hives, swelling, and asthma flares with it. So when you look at all this, you begin to understand there are things that make a big increase in risk. Now, for those folks, it's almost always don't use aspirin. So that's path and fork number 2. Here's a simple group. Plaque plus low bleeding risk. This is the simplest one. Baby aspirin often makes sense. 81 milligrams with food. Avoid the nonsteroidal anti-inflammatories, the Motrin and the Naproxen. Control your blood pressure. Monitor symptoms. This is where aspirin still does exactly what it was designed to do. And this is also the place where one of the biggest opportunities is being missed, because media outlets all the way from the New York Times to most YouTubers in this space say, don't take aspirin anymore, because they're misinterpreting the U.S. Preventive Services guidelines. Fortunately, tens of millions of people are ignoring that bad advice, and they're still taking aspirin because aspirin saves lives. Now, here's where it gets dicey, and here's where you need to focus in terms of if you're in this next category, you got to be doing some thinking. You have plaque, but aspirin causes problems. Maybe not catastrophic problems like the last group, but not really tolerable either. So now we choose instead of guessing. Option 2, same job, but a different tool. Instead of aspirin, consider something else. This is where Plavix comes in. You've heard of it as clopidogrel. That's the generic name. Plavix is an antiplatelet, just like aspirin, but it works through a different pathway. So in people with plaque, it can reduce cardiovascular events. Some people tolerate clopidogrel better than aspirin, but many don't. Now, stronger tools and wrong tools. So Brilinta, it's also known as ticagrelor. It's more potent, it's reversible. In select high-risk patients, it can reduce events more than clopidogrel. This is not a casual aspirin replacement. It's a serious hardcore replacement. Now let's prevent one of the most common mistakes you see online. People ask the question, well, why not just take Eliquis? That's apixaban. Now, again, sorry, but we got to get geeky a little bit in terms of explanation. There are 2 types of clots. Plaque rupture clots are platelet-driven. Atrial fibrillation clots, they're not platelet driven. They're driven by the chemical clotting system, clotting factors 1 through 12. So aspirin and Eliquis are not interchangeable. Here are some common real-world scenarios. Scenario 1, and let's just go through these. It'll help you understand where you might fit and what you should be thinking. Scenario 1 is you're 62 years old, your calcium score is 120, so you got a little bit of risk there. Aspirin causes stomach pain, but also black stools, so you got some real evidence that you're getting some bleeding in there. You mitigate first. If symptoms persist, you switch antiplatelets and stabilize plaque aggressively. So scenario number 2, you're 70 years old, you've had a stent before, and you have a history of a gastrointestinal bleed, an ulcer. Aspirin's probably just off the table for you, but doing nothing's really not an option either. And we'll talk about what the options are in just a few minutes. Scenario number 3, you have atrial fib and plaque. Now we're balancing 2 clot risks with 1 bleeding risk, and you might say, well, logically, this is where you are, Ford. Why don't you just take both aspirin and Eliquis or Xarelto? And the answer is these things pile up. The bleeding from the NOACs and the bleeding from antiplatelets like clopidogrel or aspirin, these things pile up the more of them that you take. There are situations where you may need to take more than one. DAPT, dual antiplatelet care, or dual blood thinners. But those are special situations after some stents, after some heart attacks, things like that. And those are also short-term, time-limited situations. For your routine person, the vast majority of us, like me, who have plaque and atrial fib, and there's a heck of a lot of us out there, we shouldn't be taking both. We should be taking a NOAC, a novel oral anticoagulant like Xarelto or Eliquis. That's where you should end up going. Again, this is not YouTube medicine. This is an individual care. This is being provided as a discussion to enlighten your discussion with your doctor. Now, having gotten all the way there, let's go back. There's a thing that we really haven't discussed yet, and it's the most obvious thing in many ways. Also the most important thing. It's the thing that gets missed more than anything else, and that is this. The best long-term protection against plaque rupture is not a pill. It's lifestyle, blood pressure control, metabolic health, knowing if you have prediabetes or diabetes, getting the proper testing for that, not just an A1C, getting an OGTT, using a CGM, looking at an insulin response, talking about lifestyle and managing plaque rupture or preventing it, smoking cessation. If you're a smoker, all bets are off. You got to stop smoking. Sleep is a big issue, fitness, exercise, and things that reduce your inflammation. These things don't just lower your numbers. They change plaque biology. They reduce the chance that plaque cracks in the first place. And that's clearly where you want to be. So if aspirin harms you, you don't just do nothing. You stabilize aggressively and choose the safest tool that still treats the risk. That's not ideology. That's just practical prevention. Question 1, do you have plaque? If no, usually no aspirin. If yes, keep going. Question number 2, what is your bleeding risk? If it's low, aspirin's usually going to work. If it's moderate, mitigate or switch. If it's high, no, have another plan. Now here's question number 3. What kind of clot am I preventing? If it's plaque rupture, it's an antiplatelet. If it's atrial fib, and atrial fib is going to trump plaque rupture, so you go to an anticoagulant like Eliquis or Xarelto. If it's both, yes, there's careful balancing, but usually it's going to be Eliquis or Xarelto. So at the end of the day, the most important thing is not any of these drugs that we just went through. The most important thing is stabilizing that plaque, no matter what, with the most effective ways to do it, and that's lifestyle. So if you felt pressured, confused, or stuck between bad choices, you're really not alone. Medicine often oversimplifies deeply personal decisions. My job is not to force aspirin or to force you on another drug. My job is to help you understand the trade-offs clearly so that you can choose wisely and have intelligent discussions with your doctor, your consultant in this journey, your navigator in this journey. If you'd like to see how I help patients protect their arteries step by step, download my free 7-step heart attack prevention guide. This will tell you how to stabilize that plaque. It's linked below or on the QR code. If you're ready for personalized help, my clinical team and I do this every day. You can call 859-721-1414 or again, use the link. And if you'd like to help us save lives with this channel, it's easy, completely free, and very, very simple. Just please subscribe. I would appreciate it so much. Growing old is just not for sissies, but it's a lot easier with healthy arteries.